Thank you for joining us for another episode of I Am Able. The goal of our podcast is to bring acceptance and awareness to our communities when working with, educating, and living with people of all abilities.
Good morning, everyone. I am Jamie Lord Tovar, and today I'm going to be talking with Dawn. We're going to be talking about NICUs. Welcome, Dawn. How are you?
I'm good. Thank you, Jamie. How are you?
I'm pretty good. I'm pretty good as well. Thanks. So, Dawn, you're an occupational therapist, correct?
Yes.
Okay. And so you have some experience in NICUs.
Yes, I do.
Okay, so for those of us who aren't real familiar with that term, can you go ahead and explain what an NICU is?
Yes. Well, NICU is an acronym for Neonatal Intensive Care Unit. So a neonatal intensive care unit is a specialty area of a hospital that specifically cares for newborn babies that have medical complications. And that may be from being born prematurely to having a traumatic birth, cardiac issues, some type of congenital defect that causes them not to be able to go home right after being born.
Okay. Oh, wow. All right. So those would all be considered traumatic births, the examples you gave us,
No.
or what are the other ones?
Sorry.
There's quite a few.
Yes. So a lot of, well, if you're born premature, it's not always because of a traumatic reason. Sometimes, mom's been on bed rest because she's been having contractions and they're not able to stop, and they kind of know the baby's coming. So it's not necessarily traumatic. Or a pregnant woman could get rear-ended at a stop sign and go into labor, and that might be a little bit more traumatic for her and for the baby, especially depending on where the delivery occurs. But sometimes when babies are born, things just don't go well. Babies get stuck. Babies start physiologically not tolerating being born. And so you have like your emergency C-sections, and you have babies who just are not able to breathe well on their own. Their heart rate isn't able to continue functioning. Their heart's not able to continue functioning the way it should, and they need immediate specialized care. So not all babies who end up in the NICU are aware that that's going to be that is going to be happening.
Okay. All right. So what are the most common reasons for that you've seen? So you've been working with the NICU unit for a few years, correct?
Yes, I've been part-time working in a local hospital at their NICU for 22 years. And recently I have kind of decreased my hours, and I'm per diem. So I mostly work summers and 2 Saturdays a month.
Oh, wow. Okay. So how is the NICU unit different from like a typical nursery?
Okay, well, so this is a little complicated, more so than one would think. So there are actually 4 levels of newborn care that require some type of medical intervention. So you have a level 1 nursery. It can be called a well newborn nursery, basic newborn care, but it's the kind of nursery that everyone expects their babies to go to when they're born. These are for babies that are born full term and who are stable. So they can breathe on their own, they can maintain their own body temperature. There's no problems with cardiac or neurological stability. So there's no problems with their hearts. There's no problems like with seizures. You can go to a newborn nursery if you're born at around 35 weeks to 37 weeks, which is considered to be preterm, but only if you meet that level of medical stability, maintaining your temperature, you're eating by mouth okay, you don't need any medical intervention. Sometimes a baby will be born and the assumption is the baby's fine, but maybe their APGAR scores were a little lower than the doctor would like, and they'll observe the baby in a well-born nursery for a couple of hours, and then maybe just to make sure they're staying stable and and everything's okay, or make that assessment that the baby needs to be transferred. So it's usually the only time that a baby that's not quite stable is in a newborn nursery, is when they're observing and trying to decide, is this baby recovering from being born, or are we still having medical issues that need further workup? There is a level 2 or something called a special care nursery. Sometimes it's called advanced newborn care. So these babies are going to have some health problems, but they're not considered to be serious. So you can have a baby in a special care nursery that's born after 32 weeks, but they usually don't need support with breathing. And they're not super small. So they're going to weigh more than like 1,500 grams, which is about 3 or 4 pounds. Okay. Sometimes babies, like if a baby is born and they have a high bilirubin, those orangey babies that need to go under the blue lights. Sometimes they'll send the babies home with a blue light blanket, and the parents will treat them at home. But if they need to come to the hospital and be treated with the blue phototherapy, sometimes they'll go to the special care nursery. If a baby goes home and runs a fever after like a day or two of being home, they might end up in the special care nursery. There's nothing severe happening with the baby, but there's still stuff going on that needs to be medically monitored.
Okay, so mom and dad or parents need just a little bit of extra help just in case something were to go wrong with those guys, but they're pretty stable. It's more just to be safe. Is that correct?
It's not, yes, basically.
Okay.
Well, it's not typical for a newborn baby to have a fever, for example. So
okay.
Sometimes if labor has been drawn out, if there's been the use of medications or procedures to kind of like move the delivery along, sometimes the baby will run a fever. And the doctors will want to keep an eye on that fever to make sure that it's not something significant. And so they'll want to monitor that baby in the hospital, not at home. If a baby is born and we're not sure, maybe the nurse saw a seizure, they're going to need to monitor that baby before sending them home. So it's kind of I guess it's just more, it's more of a just, it's for care for babies that they're not ready to leave, but they're not ready to say like, no, they need more specialized care.
Okay. So it's like, you're not completely healthy, but you're not completely sick either. You're in the middle.
Well, there's a whole transition from being born. It's like everybody's like, oh, the baby's born, everything's fine. That baby has been growing inside the mom's womb for 9 months and has been getting all of its oxygen supply from mom, all of its nutrients from mom, kidney function, liver function, all of that is being regulated by mom. And the baby has to like take on that responsibility for their own physiology. In a fairly short period of time.
That sounds so cool. We expect so much from newborns.
I know. Well, and yeah, we'll talk more about that a little later. You have a level 3 and level 4 NICUs, and that's usually I think what people think of when they think of NICUs is this level 3 or level 4. Okay. Level 3 NICUs can handle babies that are born premature, that have critical illness, severe medical complications. They usually offer really the full range of pediatric medical specialties, respiratory support, MRIs, and that sort of thing. A level 4 NICU, that's like the highest level of care for babies. So what you'll see at a level 4 is maybe a baby needs surgery for birth complications. Maybe we already know that the baby has a cardiac defect that needs to be addressed surgically. So usually those babies will end up in a level 4 because you need to have you need to have a surgeon on hand that is able to operate on a preterm baby or a full-term baby, and be able to deal with those types of cardiac issues. We have babies that need to, that due to kind of like anomalies in their anatomy, it just needs to be addressed right away, or they need to be monitored and taken care of medically from a specific standpoint. And so those babies will typically end up more at a level 4 regional NICU than a baby who just needs to be monitored, or might just be running a fever and we're not sure why.
Okay.
You may see babies get transferred from one unit to another. They may start off in the newborn and go to the newborn nursery because they need more specialized care. And then if the baby kind of has more increasing problems, end up in a level 3 or a level 4 NICU.
Okay. All right.
So see, sometimes we do have the ability to transport babies from, locally there is a level 4 NICU that has the ability to transport by helicopter babies born at some of our more rural parts of California that don't have level 3 or level 4 NICUs, and fly them in.
Oh, wow.
Yeah, so I know everybody always thinks of like, you're pregnant, you have your baby, and you go home and everything is fine. And
Right.
most of the time, obviously that's what happens. But unfortunately, sometimes things don't go as planned, and you need to have a higher level of medical support than you thought.
Yeah. So what is your role then as an occupational therapist in the NICU?
So the primary role is developmental handling, positioning, positive touch, and then feeding. And then both of those roles kind of encompass their own set of responsibilities. So depending on the baby. So if I'm working with a baby who is considered to be a small baby, so they're born less than 28 weeks, so between 25 and 28 weeks gestation, once they've been in the unit for a certain amount of time, sometimes it's like about a week, sometimes it's longer, and they've reached a certain level of medical stability, then we start to go in and just kind of do some positive touch, what's called containment. So you really just kind of put your hands on the baby and then and don't move.
Okay.
A lot of we try to encourage as early as possible that kangaroo care. So it's the skin to skin contact with a parent. It's nice when it's mom, and it's preferable when it's mom, but it can also be dad. And if the parents aren't available, and there's a surrogate parent involved, like a grandparent or a close or another family relative or a close family friend, that the parents have said, yes, we want them to do this for our child, and to start doing that as early as possible. There's a lot of poking that happens with these poor babies. They have to have IVs, they are on breathing support, they have to have their heel stick done, blood gets drawn. So there's just a lot of things that happen that are life-saving, and they need to happen, but they're not necessarily positive experiences for the baby. So we also want to go in there and make sure that the baby's experiencing positive touch is basically the term that we use. When they get a little older and they're more able to handle, and we'll start doing some infant massage. We start with the feet and kind of and work our way up closer to the body. We teach parents how to do that, so that they're not just, the idea with the positive touch and the kangaroo care and the infant massage is that you're not just coming to like stare at your baby while they lie either in an open warmer or an isolette, that you're actually participating in helping your child develop while they're in the NICU.
Yeah. So you just mentioned a warmer and an isolette. So a warmer, is that literally just like
it's that open crib bed? Yeah, well, it's an open bed, but it's got a heat lamp, and and there's ability to monitor the baby's temperature through the bed itself. There's a light above it. So it's got some things that go along with being in an open baby warmer that allows the medical team to properly care for the baby. So the light, the heating lamp is kind of like automatic. So the baby's temperature, it's programmed. So the baby needs to keep a temperature of a certain degree, and then it'll monitor. If the baby starts to get cold, it'll like kick up the heat a little bit. If the baby starts to get too warm, it'll lower itself down. So yeah, so it's more specialized than just putting like a lamp over the baby to keep the baby warm. Which is sometimes what we do when we're giving them a bath in the NICU, right? We'll get a lamp just so that it's warm, and we'll give them a bath because we don't want them to get cold, and then get them back where they belong and get their temperature, more stable again. The isolette is the enclosed bed. So the air coming into that bed is filtered. The temperature is also regulated inside the isolette too, and it also does some other things like minimize noise. And then you can also minimize light, because when you have your premature babies, they're supposed to be in utero. They're not supposed to have been born yet. They're going to have a hard time regulating their temperature. We don't want them overexposed to sound. We don't want them overexposed to light. So we put them in these isolettes, and we try to kind of, there's no mimicking the womb, but you want sound muffled, you want light muffled. Yes, as much as you can. So, and then the other thing that we do as OTs in the NICU is work on feeding. That's also something that a lot of families don't realize, or a lot of people in general don't realize. You go to a party and they're like, what do you do? And what do you do there? And it's like, oh, I work with babies because I have to learn how to eat. And everyone always takes that double take. Like, babies are born knowing how to eat. Like, well, they're born knowing how to eat when they're full term and they don't have any medical complications. When they're born prematurely or there are significant medical complications, eating doesn't come as naturally as it should, because they've got these other factors interfering with their ability to coordinate, suck, swallow, and breathe. And so they need help in that area. And that's a significant role for OTs in NICUs.
So I don't know if you can briefly tell us how you teach a baby to eat. How do you start? I mean, do you just like massage?
Well, first it starts with an assessment.
Okay.
There's specific gestational ages that you expect to see sucking. I wouldn't necessarily, and the baby also then needs to be able to tolerate being touched. So we'll know going in that, if a baby has problems maintaining their heart rate and their oxygenation when you go in and change their diaper, they're probably not going to handle anything in their mouth. And so we kind of have to build up that tolerance for handling. So that's kind of the overlap with the developmental. We need to have the positive touch. They need to handle handling. And are they sucking? Do they have that suck reflex? What are we doing to get that going? So with our premature babies, around 30 weeks or so, we'll start really kind of looking at quality of suck and endurance, and usually we're just happy with a couple of sucks here and there. We don't expect newborn sucking at 30 weeks. And around 33 weeks or so, and these are rough ages because each baby is going to be a little different, we may start doing something called taste trials, where we have a baby who does suck well on a pacifier or a gloved finger. And so we want to make sure that they're also then able to swallow, and we'll do like 5 cc's is a teaspoon. So we'll start sometimes with a half a cc. So, I mean, I don't even know how to measure that in teaspoons. This is so tiny.
Yeah.
And just to make sure that they're swallowing okay. And we'll do that a couple of times a day, and just kind of then work up to between the gestational age that's appropriate for feeding and swallowing, and what they're able to handle, and kind of work on that together. If we have a baby who's not able to swallow safely by about like that 36 to 40 weeks, around that full term age, we may start introducing neuromuscular electrical stimulation to the muscles of the throat to kind of help facilitate a stronger swallow. Depending on overall neurological status of the baby, respiratory status, you have to have that suck, swallow, breathe which means you have to be able to breathe okay. So some of our babies, because their lungs been compromised from being born early, breathe too fast or need supplemental oxygenation in order to breathe. I always try to work with the parents and say, think about walking up a flight of stairs and getting out of breath, and then my telling you, you have to drink this bottle of water while you continue up another flight of stairs. You can't do it. You
Right.
cannot breathe too fast and eat at the same time. And that is a significant problem with a lot of the babies that are born early, especially if there's been respiratory damage or there are respiratory issues, and that they're breathing too fast and so they can't safely eat. And so that becomes can we work on building endurance, or do we ultimately need to make a decision about a child needing a feeding tube in order to go home and safely be fed?
Oh, wow.
And the same is
So
true.
then,
Sorry.
go ahead.
And these can happen across the board, like our kids that have neurological issues. So maybe there has been a brain bleed, or maybe there are seizures. And so can they maintain that sucking and safe swallow? Cardiac babies that have cardiac problems can also have the same problem with coordinating suck, swallow, and breathe, because the heart can affect your respirations. If the heart's not pumping efficiently, then sometimes we breathe too fast to compensate for that. Excuse me.
Got you. Wow. So it sounds like that you spend a lot of time with each of your patients when it's a eating issue or sucking, swallowing. How often when you go and see a patient, how often do you see them, and how long generally do the sessions last?
Well, we usually so each hospital is going to be different in terms of the frequency of therapy services, and some of that's going to depend on the baby. If we have a baby that it's kind of low endurance, maybe we're going to do an assessment and set up feeding strategies so that everybody kind of knows, okay, this baby gets tired quickly and these are the strategies that work best. There are different kinds of nipples, bottle nipples that we use. Some flow a little faster than others. And so for some babies, we'll have them on the slowest flow possible because that helps them with their swallowing. We also like work on breastfeeding, but we can talk about that later. So we don't usually want a baby to eat for longer than 20 to 30 minutes, depending on their overall condition. Anything longer than that, they're just burning calories and they're getting, and we're just fatiguing them. But the therapy session may last longer depending on what else we're doing with them. The sessions usually, I would say, unless I'm doing an intensive family training, my sessions are as anywhere from a half an hour to an hour. But if I am working with a family who has lots of questions or needs more support, the session may go longer, but that's not typical.
Okay. Right.
Then again, depending on the baby and depending on the hospital, I may be seeing the child 5 days a week. I may be seeing them 3 days a week. It may be an evaluation and just like, you know what, they don't really need us, so we're not going to see them at all. So it is very individualized. Because I work on Saturdays, I'm usually seeing the babies that are having significant issues with feeding, and we're giving that extra. Therapy sessions are usually Monday through Friday. So if they're being seen on Saturday, then it's usually because they need extra support to get the eating going.
Okay. That makes sense. So it sounds like there would be some overlap in services with these patients. Are there other services that are going to be helping with like the feeding aspect and
But
like
yes.
that?
So again, it's going to depend on the hospital. So some hospitals have just OT that works in the NICU. Some will have PT. Some might have speech, and some have all three. So our OTA, or actually our licensure law in California states that I can only treat a patient that's been evaluated by an OT. So we usually end up splitting the caseload, taking turns treating patients. So you'll get so maybe PT seeing a baby, but they are like, you know what, there's some sensory issues that are going on. We want OT to come in. OT might start feeding a patient that has some specific laryngeal or pharyngeal issues. It's like, you know what, let's get speech therapy involved. So you have to work as a team, because you don't want to have duplication of services, but at the same time, you want to make sure that the baby's getting all the services that they need. We do also work with lactation consultants in the hospital with getting the premature babies and the babies that are medically fragile up and eating. And so if I know that lactation is going to work with mom on Tuesday, then I'm not going to treat that patient on Tuesday. I'll just come in on Wednesday and do something else, or I'll work with on the bottle feeding and let the lactation consultant work with the mom on breastfeeding. So it's sometimes it's the need of the patient. Maybe they need a lactation consultant to work right now with the family, and there's not one available, so I'll just step in and do it. Some of the some OTs and some speech therapists are also licensed lactation consultants. So there's and some are also certified in infant massage. So there's a National Association of Neonatal Therapists, and so there's lots of people who have additional certifications besides their primary PT, OT, or speech therapy license.
Okay. All right. You just answered my next question, which was, what kind of special training do you need?
You don't there right now, there isn't a specific like certification course to be an NICU therapist.
Okay.
However, nobody's going to hire a therapist to come work in their unit that either doesn't have experience or they don't offer some sort of mentorship program. So typically, to even be able to be considered for an NICU position, you typically have to have at least 2 or 3 years experience. Some facilities want 5.
Okay.
And then usually you're shadowed, which means you're following the primary therapist. And then as you get better at some of your skills and learning about what to do with the babies, premature babies they're not just small newborn babies. They're still developing as though they would be in utero. So their sensory system is different. Some babies, if they're born early enough, their eyes are still fused. They haven't been able to open their eyes yet. So there's so you need to be able to know how to assess where the baby's at and what kind of handling they can tolerate, because you don't want to go in and treat a 30-weeker as though they were just a small full-term baby.
Okay, yeah. Okay. So how long had you been in occupational therapy before you started working in the neonatal unit?
That's a good question. Let's see. I've been in OT for 33 years and I've been in the NICU for 24. So you can do the math and you
Okay,
can how many years I was working.
Wow. Okay. Yeah.
So, and then even with that training, the hospital I was at the time did send me to an NICU at another hospital for a number of, I forget how many, because that was back 22 years ago, but I did go to another hospital for like that shadowing and for that initial training. And then we did have one therapist who had NICU experience that then continued the training.
Oh, okay.
So yeah, I mean, I've done training for like new staff who wanted to come in, and usually, like I said, they have several years experience. Having inpatient experience is always good because it's nice to be comfortable around, the nasal cannula or a patient on a ventilator, or just, the lead wires that are monitoring heart rate and respirations and O2 saturations and that kind of stuff. And so it can be a little nerve-wracking, even as a therapist, to go in there and be like, I have to do what? And like, look at all these lines. So having that kind of experience helps also. And it can take, like, even having done this for 22 years, the thing that's incredible about medicine is that they're always finding new ways to help people. So every now and then I will get a patient and it'll be like, I've never heard of this diagnosis before. And I'll have to go back to my team and be like, what are we doing here? So there's always learning that has to happen. We do have typically you would have somebody representing the therapy team at rounds, when the doctors are kind of going over the general case caseload so that you're getting your education from the doctor. Like, oh, we have this kiddo, they've had this surgery. This is the first time we've ever done this. This is what you should see. If I'm seeing something that hasn't, that I'm a little concerned about, I'll either go straight to the doctor and have a conversation with them, or my team member who goes to rounds will bring that up. Like, hey, we're seeing some swelling. We didn't think we were supposed to. And it's like, oh no, it's fine. Don't worry about it. Okay. Then,
Okay.
we'll
Right.
continue working. So it's you're not working in isolation. You're part of a team, and people want to know how the baby handled your session. You need to know how the baby handled other people's sessions. You really have to have a great relationship with your nurse, because if your nurse is like, hey, I don't know that today's a good day for intervention. We had this and this happen this morning. Then you need to be able to go, nurse said no, and be okay with that, and not try to challenge anything.
Okay. So there's a lot of trust amongst the different providers of the various care. It sounds like there has to be a lot of trust in order to get this to work.
Yes. Well, because if your nurse doesn't trust you, she's not going to let you touch your patient. And then you
Right.
can't help your patient if your nurse won't let you touch her, And well, and if the parent doesn't trust the nurse, then, then they're just anxious, and they're not open to learning, because their concern is somewhere else.
Got ya. So can you tell me about some of the successes that you've had with treating this population?
So that's kind of an interesting question for me.
They're all successes if they get to go home, right?
So, I mean, yes, right. Like, is a success a child who doesn't need the feeding tube and gets to eat completely? But I wouldn't say it wasn't a success of a child who does go home with a feeding tube, as long, especially if you have like a plan in place and the family's comfortable and the child's still making progress. So I think that a success for me as a treating therapist in the NICU is that I've been able to make a relationship with a family that they feel that their experience with me in therapy and their child in our facility was as positive as possible. Right? Nobody wants to have a child born in the NICU. Nobody wants one that has medical complications or concerns, worries.
Right.
If I can get a parent to leave and at least be able to look back on their experience as being as positive as possible, then I actually consider that to be a success. Because they don't,
right.
They can only do what they can do, and to kind of like put that on, and to put that expectation, it's just not fair to the family or the baby.
Yeah. Okay. Yes. I guess really my question was that were there any examples of a baby that you thought that did even like much better than you expected, that, just
that happens all the time. Unfortunately, it happens both ways. I have babies that like, why aren't you doing better? Like, this doesn't make any sense. And you have other kids that are just like, wow. But really where you see those, I guess, successes then would be when there are certain criteria that a baby has to meet. And almost all of our preterm, anyone born under 32 weeks automatically meets that. We have a high risk follow-up clinic. Most hospitals are required, at least in the state of California, for certain types of funding, to have some type of high-risk follow-up clinic. So the babies receive developmental assessments at around 6 months of age, adjusted. So if you're born 3 months early, you might be 9 months, but adjusted to 6 months, and then you'll get your first developmental assessment. Then you come back at around 15 to 18 months, and then sometime after 2. And we do these developmental assessments. And sometimes you'll see kids that come back and you're just like, wow, like, as sick as you were, as complicated as you were, like, look at what you're doing. I have had some kids come back that I was just kind of surprised at that some of the struggles they were having. And then sometimes you're just kind of pleased with how well somebody's doing for just what was expected of them. So we have had some kids that were not expected to be very interactive because of just because of the level of medical complications. And they're able to interact with their family on that level that they're able to do, and the family, and they're able to bond with their parents, and the parents are able to bond with them. And so that is also, I would consider to be a success, when a family comes in and they've bonded with their child, as well as measuring those developmental outcomes. How OT is that?
That was very OT. Very good.
But it's kind of like, but it's true at the same time. It's like, nobody ever wants to take away from somebody for not being somebody else. You want somebody to thrive in being who they are. And it's the same for these kiddos. That's why that question I did kind of get stumped on when I was thinking about it. Oh, that's not how we see things.
Right. So are there any other we've talked throughout this interview about some challenges facing the population. Are there any other challenges that you want to talk about, or maybe just want to give some advice to families that have a child who's having some sort of incident?
Well, I think because it's a kind of a combination of both those questions. Our biggest challenges tend to be families that don't communicate well. So I mean, I've been in a room where a surgeon's come in, talk to the mom, and asked, "Do you have any questions?" She said no, and then leaves, and then gets on the phone with her husband, and is like, "The surgeon was here. I didn't understand anything he said." And I'm like, "No, like that's not okay." And then to try and get that surgeon to come back in the room is just a lot of work, and there's a lot of it's sometimes it's hard when you're in the medical field and you're in this kind of like level of medical care and the terminology that gets used to sometimes slip into that jargon. I'm sure I did that like 500 times during this interview. I said I wasn't going to do that. And then to realize that people don't know what you're saying. And so it's important to be able to, that the family be able to ask those questions and get those answers, so that they feel they have to feel comfortable with their baby in the hospital. So you'll have families that are not comfortable and they're there 24/7, and they're and because they're so anxious, it makes for difficult communication. Or you'll have families, in the other extreme, they're not comfortable with what's going on and they're scared, so they disappear on us. And that's not okay either. Something in the middle is ideal. And I get people don't want other people knowing like their business, but it's helpful if your nurse knows that you've got 3 other kids at home and no transportation and no babysitters, rather than everyone thinking, where'd this mom go? Is she taking the baby home? Like, she hasn't called. We haven't heard from her. She's not responding to our phone calls, when it's like she's trying to deal with this personal crisis and doesn't want us to know what's going on, and so I would say you kind of need to, because there are things that we can do to help. There are a lot of hospitals in your Ronald McDonald homes. So if you live far away, or you don't have great transportation, maybe we could get you in a Ronald McDonald house. Pre-COVID, a lot of hospitals had not babysitting, but they did have like playrooms for siblings of a certain age.
Oh, nice.
During COVID, and I don't know that any of them have opened up just yet, but hopefully those will come back. But if we don't know you need the help, they do, especially for, I know for sure for moms who are breastfeeding, but sometimes for other families as well, they'll give vouchers so that you can go get lunch at the cafeteria, so that it's not like you disappeared for 4 hours because you had to eat something and you needed to go home to make a sandwich because you couldn't afford
okay.
to buy lunch at the cafeteria.
So you don't think of those things. Yeah.
We've done cab vouchers and bus vouchers but like I said, if we don't know there's a problem, then we can't help out. So communication, I would think, is the biggest challenge.
Okay.
And
so
then,
it sounds like really want to know their business. I mean, it's like, please, no, tell us everything. Leave nothing out, and then we'll decide what's important.
Well, yeah, I mean, we don't need to know that you got into a fight with your husband last night. But yes, it's like, or your spouse, I should say. But it's just sort of we don't need to know. I mean, and sometimes we find out that information as well, like who's arguing with who and who's not allowed to come visit and who knows what. But if it affects the care of the child in the hospital, then it is important that we know.
Better to know than not.
Yeah. And then just the other big challenge is that because most premature births or most traumatic births are not expected. There's just a lot of anxiety and even sometimes anger issues, involved there too. And a lot of just a lack of understanding, not understanding like, okay, my baby was born this way, how come they're not eating? And then having to explain, well, they're breathing too fast. Well, that doesn't make any sense. All babies eat okay. And so we do have to deal with that issue a lot too, where just a kind of a general lack of understanding about anatomy and physiology and neurology and the impact on like how we function. Sometimes it's somebody's first introduction to things.
Right. They don't have a handbook for parenting, right? So if this is especially if your first child, I would think this would be especially traumatic, if not knowing how babies typically act or anything.
Yes. So, and that's usually where the challenge comes in as a therapist is just being supportive and kind of just understanding, like, I've been doing this for 22 years. And I have to explain this to parents, like sometimes to moms all the time. I've been doing this for 22 years. So I'm going to be a little bit better at feeding your baby than maybe you are, because this is the first time you've ever fed a premature baby.
Right.
It doesn't mean you're a bad mom. It just means you're inexperienced. Like I usually try to explain to the parents, your baby is learning to eat, you're learning to feed them. You'll both get better at this. The more, but you guys have to practice together.
Right.
Every now and then we will have a baby who will eat better for one person over another person. That one person has to be mom. It can't be me. I'm not going home with you. The baby is. And so, sometimes it's like, we got to get you here more frequently because your baby needs to like get used to your style of feeding so that everything goes well when you leave.
Okay. Yeah.
But
that's got to be for a new parent, having somebody else who's better at taking care of their child, like with the feeding, has got to do something to their ego, I would think, even if they know, right, I'm just starting this, and here Dawn has all this experience. But I could see where it would be kind of daunting for a new parent, especially.
And it kind of depends on when where you are in the feeding cycle. Most, it doesn't happen a lot, but it has happened where I've had, it's come up as an issue, and it's just like, yeah, but that's what we're here to teach you so that you can then do this, and then just make sure that parent is comfortable, and gets as much practice in. So by the time that the baby is ready to go home, they're like, oh, I don't need your help. Go. And then, relief.
Like, yay!
It's a team approach, and I think that also gets a little challenging for families. Also, it's just sort of like, yeah, you're not really, like, there's some things, there's some things you get to still be in charge of, breast milk or formula.
Okay.
You can ask, the babies are usually on a feeding schedule. You can ask what those times are, but then there are some other things that like are kind of beyond your control as a parent, and that can get frustrating.
I can imagine. So do you have any other advice for parents then that are going through this with a child in the NICU?
No, I would say that if you really are having a hard time kind of like making that professional relationship or creating that professional bond with your therapist, that it's okay to say something.
Okay.
I mean, I don't necessarily want to say that like, oh, like, I don't like this nurse and I only want that nurse, and, and kind of make put yourself out there as being kind of difficult. But at the same time, if somebody has a style that really is like kind of rubbing you the wrong way and making you not comfortable with the care your child is getting at the hospital, there's always a charge nurse that you can go to and just have like a kind of like a calm conversation about.
Okay.
I know the nurse is licensed. I know the therapist is licensed, but sometimes they say these things and I just think they're not sensitive enough to what's going on in our family, and then kind of like take it from there. I think that anyone who feels that they are stuck with having to deal with a certain person and it's making their experience more complicated, it doesn't have to happen. Plus, we all need to know that too. I mean, I had a parent tell me, working on feeding, I think I said something like, it was an ex-NICU baby when I was seeing them as an outpatient. We were still working on feeding, And I said something about what good work the child was doing. And the mom was kind of like, hey, they're eating. I don't want her thinking of eating as work. Can you use a different word? And I've stopped using that. I've stopped using work because it never even occurred to me that that the child could then associate work with eating, and then it might turn them, behaviorally, or, eating. And I stopped using it, and so sometimes the feedback is just nice to hear anyway, like, oh, it would be better if you said this instead of that, and or just don't say that and come up with a different word on your own, and and have us change how we're doing things, because that's because we're all about that. We all want to be, I don't want to be the therapist that like, I'm not coming at 12 if she's going to be there. I want to be the therapist that you're like, oh yay, Dawn's coming at 12. I'm looking forward to her working with the baby. And if I'm saying something or doing something that is making that not happen, then I need to know what it is so that I can change it.
Right. Yes. So the parents, I think, maybe need to realize that, as service providers, as medical professionals, that we're not going to take their feedback negatively if it's presented, in a positive way. It's like, everybody sees things differently, and, we're here to please and work together. So they feel free to, constructive criticism is helpful.
It is. And I've had parents yell at me. I've come in the room and I've gotten yelled at, and it's my first time meeting them. And I was just, because they're frustrated with someone else, and, and it's just kind of like, okay, well, what do you want to see happen? And we'll do our best to change. I mean, I've had families get upset because they can only come at 5 o'clock at night, and the child's only getting therapy at 9 o'clock in the morning. Like, okay, we'll see if we can find somebody who's going to be here that late, or like maybe, somebody will stay that late at least once or twice a week, so that we can accommodate your schedule. But if we don't know that you want that schedule accommodated,
right.
Because honestly, most of the time we're sitting there going, I don't know where the parents are. They don't come during the day. They only come at night. And, and then we just do our thing and we leave. And so it's not intentional. It's just that we weren't even aware that a later afternoon appointment was possible. So that happens sometimes. Just miscommunications. So yeah, so whether communication is or not, it'll still get addressed. I guess is the point of that. It's preferable if it's done nicely.
Right.
Because my heart's not racing, and I'm not sweating, and I'm not like,
it's all better.
But we're all, we're all people. Like, we're all human. Nobody should be walking in anyone's room with any kind of like, I'm perfect and kind of attitude. So I have feelings also, and they can also be hurt. So
right.
Not that that's a parent's concern, but
right. It's a good thing to keep in mind, though. All right. Well, are there any other words of advice you might want to give to people to help support families that are going through challenges with the child in the NICU?
Well, I think some of those challenges are going to be ongoing, and so again, it's just a continuation of what I was just saying, is just making sure that you're with a medical team, whether it's a doctor or a therapist, that you trust them, and go with your gut. If you feel like somebody's giving you information and it's not accurate, it's fine to get a second opinion or to change medical professionals.
Okay. All right. Very good. Well, Dawn, I think you've answered all of my questions. Is there anything else that you'd like to add before we end?
No, I think unless you want to keep going for another hour and a half, I think we should call it quits.
Well, maybe we should have you come back and talk again. That would be amazing. I feel like with this subject, we could definitely go on, but I don't know if our listeners are going to want us to go on for too much longer today.
So,
thank you. So if there's nothing else, thank you so much for taking the time to talk with me today, and definitely helped educate me a little more on what goes on in the NICU, and hopefully our listeners will also be well educated now on things that happen.
Right. Oh, you're welcome. Thank you for having me.
It was my pleasure. All right.